Basics of Medical Biochemistry. First edition, 2023. Chapter 15. Electrolyte Metabolism and Acid-Base Homeostasis. Part 2 of 2. By Professor Dr. Muhammad Jawad. MBBS, Pfau, M. Philosophy, Ph.D., Dip M.E. Head of the Biochemistry Department-Fazaia Ruth Pfau Medical College Air University-PAF Base Faisal-Karachi-Pakistan. Ex-Professor of Biochemistry, Qassim University Kingdom of Saudi Arabia. Ex-Professor, Head of the Biochemistry Department and Vice Principal. Liaquat College of Medicine and Dentistry and Fatima Jinnah Dental College, Karachi, Pakistan. 15.6 Regulation of acid-base disturbances. The acidity and alkalinity of a solution are measured by the pH scale. pH is defined as the negative logarithm of H+ ion or H3O+, hydronium ion, concentration. Mathematically it is expressed by the following equation. pH equals log H+ or log H3O+. The pH is a measure of the activity of the hydrogen ion and is reported as the reciprocal of the logarithm of the hydrogen ion activity. Therefore, water with a pH of 7 has 10 to 7 moles per liter of hydrogen ions, whereas, a pH of 6 is 10 to 6 moles per liter. The pH scale ranges from 0 to 14. Pure water has a pH of around 7, at a temperature of 25 degrees Celsius. When an acid is dissolved in water the pH will be less than 7, and when a base, or alkali is dissolved in water the pH will be greater than 7. A solution of a strong acid, such as hydrochloric acid, at a concentration of 1 mol/dm3 has a pH of 0. A solution of strong alkalis, such as sodium hydroxide, at a concentration of 1 mol/dm3 has a pH of 14. Thus, measured pH values will mostly lie in the range of 0 to 14. Since pH is a logarithmic scale, a difference of 1 pH unit is equivalent to a 10-fold difference in hydrogen ion concentration. The pH of blood is 7.35 to 7.45, the average being 7.4 used practically at most. This value of pH corresponds to H+ of 0.00000004 EQ/L or 14 EQ/L or 14 mol/L. The regulation of blood pH around the normal range is very much necessary to maintain overall body functions at a normal physiological state. A slight change in pH causes a serious and deleterious effect on body vitality. The acid-base balance of the ECF is maintained by following three mechanisms. Chemical buffering systems of blood, ECF and ICF. The lungs, to control the elimination of CO2. The kidneys, to eliminate H+ and regulate HCO, 3. Buffer solutions have a crucial role in the regulation of the acid-base balance of the body. It is a solution that resists change in pH when small amounts of either acid or base are added to it. It is a mixture of a weak acid and its conjugate base or a weak base and its conjugate acid. The main buffer system of the body is bicarbonate buffers, HCO, 3/H2CO3, hemoglobin buffers, HB/H.HB, protein/H.protein, phosphate buffers, HPO42/H2PO4, and organic acid anion/H.organic acid buffers. The bicarbonate buffering system is regarded as the first line of defense against any change in body pH. It is the most abundant blood buffer. The Henderson-Hasselbalch equation represents the relationship between pH, pKa, and the buffering action of a weak acid and its conjugate base. Mathematically, it is represented as pH equals pKa plus log base/acid. It shows that the pH of a buffer solution is dependent on the log of the ratio of base, salt, to acid at a certain temperature. As pKa is a fixed value which is the negative log of dissociation or ionization constant of acid. The pH is equal to pKa when acid is exactly half neutralized, i.e. base equals acid. At this condition, pH equals pKa plus log base/acid. pH equals pKa plus log 1/1. pH equals pKa plus 0. pH equals pKa. Table 15.4 Normal values of some important blood parameters used in the assessment of acid-base disorders. Blood gas parameter. Parameter reported end. Symbol used. Normal value. Carbon dioxide tension. Partial pressure. PCO2. 35 to 45 mmHg, average 40. Oxygen tension. Partial pressure. PO2. 80 to 100 mmHg. Oxygen percent saturation. SO2. 97. Acid-base status. pH. 7.35-7.45. Bicarbonate ions. HCO3. 22 to 30 milliequivalent/L or mol/L. Hydrogen ion concentration. H+. 40 nc/L or nmol/L. 15.7 Types of acid-base disorders. Acid-base disorders fall into four main categories: metabolic acidosis, metabolic alkalosis, respiratory acidosis, and respiratory alkalosis. Plasma pH may be affected by a change in either the HCO3 or the PCO2. Acidosis is characterized by upward arrow H+ with downward arrow pH, while alkalosis is characterized by downward arrow H+ with upward arrow pH. Abnormalities in acid-base status are classified as to whether the primary abnormality lies with the alteration in HCO3 or PCO2. If HCO3 is primarily affected, then a metabolic disturbance is present. If PCO2 is primarily affected, then a respiratory disturbance is present. Table 15.5 Types of acid-base disorders. Acid-base disturbance. Type of disorder. Primary change in HCO3. Metabolic disorder. Primary change in blood PCO2. Respiratory disorder. Table 15.6 Acid-base changes in acidosis and alkalosis. Thicker arrows indicate primary disorder, upward arrow, increase, downward arrow, decrease, N, normal. Acid-base disorders. pH. HCO, 3, mol/L. PCO2, mmHg. Metabolic acidosis. Downward arrow. N or downward arrow. Metabolic alkalosis. Upward arrow. N or upward arrow. Respiratory acidosis. Downward arrow. N or upward arrow. Respiratory alkalosis. Upward arrow. N or downward arrow. 1. Metabolic acidosis, upward arrow H+ and downward arrow pH. It is the condition characterized by a primary reduction in HCO3 and ECF and blood with a secondary rise in H+ concentration. The main reasons for metabolic acidosis are: upward arrow production of H+, ingestion of H+, drugs, impaired excretion of H+ by kidney, loss of HCO3 by GIT, loss of HCO3 by kidney, upward arrow in anion gap. Metabolic acidosis frequently occurs in renal diseases, organic aciduria, aminoaciduria, hepatitis, cirrhosis, diabetes mellitus, diabetic ketoacidosis, lactic acidosis, aspirin/salicylate poisoning. It also causes respiratory alkalosis by producing hyperventilation, hyperthyroidism, adrenal insufficiency, alcoholism, starvation, loss of alkali in diarrhea or intestinal fistula, etc. 2. Metabolic alkalosis, downward arrow H+ and upward arrow pH. It is the condition characterized by a primary elevation in HCO3 and ECF and blood with a secondary fall in H+ concentration. The main reasons for metabolic alkalosis are: loss of H+, ingestion of alkali, K+ deficiency by diuretic, example chlorothiazides, therapy, hyperaldosteronism, multiple blood transfusions due to the administration of sodium citrate. Metabolic alkalosis is most commonly seen in prolonged vomiting and upper GIT obstruction. These conditions are chloride responsive. Other conditions of metabolic alkalosis include diseases of the adrenal glands such as adrenal tumors and Cushing syndrome. These conditions are chloride resistant. 3. Respiratory acidosis, upward arrow PCO2 and downward arrow pH. It is a condition characterized by a primary increase in PCO2 in the blood due to hypoventilation. It may be acute or chronic. Acute respiratory acidosis occurs within minutes or a few hours. It is uncompensated by renal factors. The main reason for acute respiratory acidosis is the sudden blockage of respiratory passage, as in choking, bronchopneumonia, an acute attack of asthma, narcosis and sedative, paralysis of respiratory muscles. Chronic respiratory acidosis occurs in long-standing conditions with impaired alveolar ventilation. Its compensation is maximal by renal mechanism. It is compensated by increased H+ excretion by the kidney and increased plasma HCO3. It is mainly seen in chronic bronchitis and emphysema. 4. Respiratory alkalosis, downward arrow PCO2 and upward arrow pH. It is a condition characterized by a primary decrease in PCO2 in the blood due to hyperventilation. The concentration of HCO3 is either normal or decreased to compensate for the situation. The main reasons for respiratory alkalosis are stimulation of the respiratory center, salicylate poisoning, hyperpyrexia, hysteria, hypoxia, example pneumonia, asthma, exercise, anxiety, example apprehensive blood donors, effects of high altitudes, septicemia and meningitis. 15.8 Compensation for acid-base disorders. The purpose of the compensation is to return the blood pH to normal. The change in the PCO2 in metabolic disorders represents the lungs' role in compensation. The change in the bicarbonate level represents the kidney's attempt to compensate for respiratory acidosis or alkalosis. Table 15.7 Compensatory acid-base response. Acid-base disorder. Compensatory response. Metabolic acidosis. Respiratory alkalosis. Metabolic alkalosis. Respiratory acidosis. Respiratory acidosis. Metabolic alkalosis. Respiratory alkalosis. Metabolic acidosis. Terms used in the description of compensation. Compensated, when compensatory mechanisms have come into play in a normal manner, does not necessarily imply that the plasma pH is within the normal range. Uncompensated, when compensation cannot occur due to some anomaly, the patient does not exhibit any sign of compensation. Partially compensated, it is the intermediate state where compensation is occurring but is not up to the required level. Table 15.8 Compensation for acid-base disorders. Acid-base disorder. Plasma pH. Primary disturbance. Mechanism of compensation. Metabolic acidosis. Low. Decreased HCO3. Hyperventilation with resulting low PCO2. Metabolic alkalosis. High. Increased HCO3. Hypoventilation with a resulting increase in PCO2. Respiratory acidosis. Low. Increased PCO2. Increased renal net acid excretion. Increased renal reabsorption of HCO3. Decreased excretion of HCO3 in urine. Respiratory alkalosis. High. Decreased PCO2. Decreased renal net acid excretion. Decreased renal reabsorption of HCO3. Increased excretion of HCO3 in urine. 15.8.1 Compensation in metabolic disorders. Metabolic disorders are compensated by the change in the PCO2, it represents the role of the lungs in compensation. It takes up to 24 hours to return the pH to normal. Hyperventilation and hypoventilation are the best ways of compensation for metabolic acidosis and metabolic alkalosis respectively. Figure 15.2 Compensation in metabolic acid-base disorders. 15.8.2 Compensation in respiratory disorders. it is a two-phase process. I. Acute response, it occurs within initial 10 minutes. It involves blood buffers. 2. Chronic, renal, adaptation, it is for up to 4 to 8 days. The change in the bicarbonate level represents the kidney's attempt to compensate for respiratory acidosis or alkalosis. pH returns to normal but not pH 7.4. Changes in HCO3 concentration occur up to 4 days in respiratory acidosis and 8 days in respiratory alkalosis. Figure 15.3 Acute and chronic compensatory responses in respiratory acidosis and alkalosis. 15.9 Role of bicarbonate buffer in acid-base regulation. The normal range of blood pH is 7.35 to 7.45. Changes in pH below 6.8 and above 8.0 may result in death. The bicarbonate buffer, HCO3/H2CO3, is the first line of defense against any change in body pH. The pKa value of carbonic acid is 6.1, which is close enough to the physiologic pH to make it a good buffer. The ratio between HCO3 and H2CO3 in this buffering system is 20:1. That's why it is also known as alkali reserve. Carbon dioxide is the main acid produced in the body. Its daily production is about 400 liters. Inside the RBCs, CO2 combines with H2O to form carbonic acid, H2CO3, by the enzyme carbonic anhydrase. Carbonic acid rapidly dissociates into H+ and HCO3. The H+ ions are buffered by deoxyhemoglobin, Hb, by the following reaction. H++ Hb rightward arrow H.Hb. In this way, H+ ions are transported in association with deoxyhemoglobin, from peripheral tissues to the lungs. In the lungs, H.Hb decomposed and H+ ions are released. H+ ions recombine with HCO3 to form H2CO3, which dissociates to form H2O and CO2 again. The CO2 is then breathed out. This system of CO2 transport is termed the isohydric transport of CO2. It is highly efficient, that there is only a minor difference in pH found between arterial and venous blood. 15.10 Role of lungs in acid-base regulation. The acid-base balance of the body is greatly affected by pulmonary function and CO2 homeostasis. The change in the PCO2 in metabolic disorders represents the lungs' role in compensation. The amount of CO2 in the blood is directly related to PCO2. The PCO2 provides a good index to assess the adequacy of ventilation. An increase in arterial PCO2 acts through the respiratory center to increase the rate of pulmonary ventilation, while a decrease in arterial PCO2 reduces the rate of ventilation. CO2 elimination. CO2 elimination through the lungs must be matched with CO2 production for adequate ventilation. There is never any significant barrier to CO2 diffusion, i.e., CO2 diffuses freely. CO2 tensions are equal in alveolar air and arterial blood. Thus, PCO2 is the direct and immediate reflection of the alveolar ventilation concerning the metabolic rate. Hyperventilation, alveolar ventilation above metabolic needs, causes alkalosis, increase in blood pH above the normal 7.4, as a result of the excess excretion of CO2 from the lungs. It is an effective way of compensating for metabolic acidosis. Lowering the PCO2 in hyperventilation causes the following reaction to proceed to the left, with consequent lowering of the H+ concentration and ultimately elevation of pH. H2CO3 leftward arrow H++ HCO3. The direct cause of a lowered PCO2 is always alveolar hyperventilation. Hyperventilation causes respiratory alkalosis and a rise in the pH of the blood. It represents an effort to raise the PO2 at the expense of excreting excess CO2 from the lungs. Hyperventilation commonly occurs in asthma and pneumonia. It is also seen in brain injury, tumors, aspirin poisoning and various conditions of anxiety. Figure 15.4 Role of lungs in compensation for acidosis. Hypoventilation, alveolar ventilation insufficient to meet metabolic needs, causes acidosis, decrease of the blood pH below the normal 7.4, as a result of the retention of CO2 by the lungs. It is an effective way of compensating for metabolic alkalosis. Raising the PCO2 in hypoventilation causes the following reaction to proceed to the right, with consequent elevation of the H+ concentration and ultimately dropping of pH. H2CO3 rightward arrow H++ HCO3. The direct cause of a raised PCO2 is always alveolar hypoventilation. Hypoventilation causes respiratory acidosis and a fall in the pH of the blood. It represents an effort to increase the PCO2 by reducing the rate of respiration. Hypoventilation commonly occurs in emphysema and chronic bronchitis. It is also seen in narcotic and barbiturate drug overdose. Figure 15.5 Role of lungs in compensation for alkalosis. 15.11 Role of kidneys in acid-base regulation.
The kidney makes a long-term adjustment in the rate of acid excretion. It cannot adjust the pH within minutes, as respiratory mechanisms. It continues to function for days until the pH has returned to normal, or near normal range. The change in the bicarbonate level represents the kidney's attempt to compensate for respiratory acidosis or alkalosis. Changes in HCO3 concentration occur up to 4 days in respiratory acidosis and 8 days in respiratory alkalosis. The following are the roles of the kidney in maintaining pH homeostasis.
1. Reabsorption of bicarbonate in proximal convoluted tubules. All bicarbonate filtered by glomeruli is reabsorbed in proximal convoluted tubules. This is the reclamation or conservation of bicarbonate. If bicarbonate, which is freely filtered at the glomerulus, is not fully reabsorbed by the tubular system, then there will be ongoing losses of the essential buffer through the urine. Figure 15.6 Reabsorption of bicarbonate in proximal convoluted tubules. 2. Secretion of H+ ions in proximal convoluted tubules. In the proximal convoluted tubules, where bicarbonate is reabsorbed at the same time H+ ions are secreted into the tubular fluid. As a result, urine become acidic by a decrease in 0.5 units of pH towards the end of this tubule. 3. Acidification of urine in distal convoluted tubules. The proton pump of specialized cells of distal convoluted tubules called I cells is responsible for the secretion of more H+ ions into the tubular fluid. This pump is also known as H+K+AT passe. It is aldosterone dependent and secretes H+ ions for the exchange of K+ ions. Following buffering mechanisms take place in distal convoluted tubules to deal with secreted H+ ions. I. Role of sodium phosphate, Na2HPO4/Na2PO4, buffer. The filtered Na2HPO4 is dissociated into Na+ and NaHPO4. The Na+ is reabsorbed for the exchange of H+. The H+ combines with NaHPO4 to form Na2PO4, which is excreted in the urine. This is also called the excretion of titratable acid. Under normal circumstances, the ratio between H2PO4 and HPO42 is 10:1. In acidosis, this ratio is raised up to 50:1 in order to remove more and more H+ ions. Figure 15.7 Role of sodium phosphate, Na2HPO4/Na2PO4, buffer. 2. Formation of NH3 and NH4+, ammonia, NH3, is formed in the kidney by the breakdown of glutamine, by glutaminase, and other amino acids delivered from muscle and liver cells. Ammonia, being a gas, diffuses rapidly across the cell membrane into the renal tubular lumen, where it combines with H+ ions to form ammonium, NH4+. In this way, H+ ions are trapped in the form of NH4+ ions, which cannot easily cross the cell membrane and are excreted with anions such as phosphate, sulfate, and chloride. Daily production of NH3 is about 40 to 50 mol, which is increased up to 400 to 500 mol in acidosis. Ammonia formation is decreased in alkalosis. Figure 15.8 Formation of NH4+ from glutamine in renal tubules. 3. Excretion of H+ ions as free acids. In severe conditions of acidosis, example in diabetic ketoacidosis, there is excessive production of ketone bodies such as sodium acetoacetate and sodium hydroxybutyrate. These are produced in so large amounts that the kidney is unable to reabsorb them completely. Actually, they have crossed their TM values, i.e., the maximum tubular concentration of a substance above which it starts appearing in the urine. In the tubular lumen, their sodium is replaced by H+, and in this way, the kidney excretes an excess of H+ to control the condition of acidosis. The Na+ ions are reabsorbed and free keto acids are excreted in the urine. For acidification of urine in collecting ducts, the numbers of I cells and proton pumps are very less in collecting ducts. Here Na+ reabsorption takes place under the influence of aldosterone for the exchange of K+ mainly and to a lesser extent for H+ in the specific cell called P cells. In fact, H+ and K+ compete with each other. Among the K+ and H+, the ion which is more in tubular cells will be secreted more into the lumen. In the case of acidosis, more H+ ions are secreted, while in the case of alkalosis, more K+ ions are secreted and then excreted in the urine. Figure 15.9 Role of NH3 as a buffer in the renal tubule. During compensation for respiratory acidosis, assisted breathing may be required. A respirator is used to assist breathing by expelling CO2, thus reducing PCO2 in blood. Bicarbonate is generated and reabsorbed by renal tubules. The renal system excretes H+ in urine while renal bicarbonate is returned to the blood to bring up pH to normal. Table 15.9 Values of pH, PCO2 and HCO3 in various acid-base disorders, upward arrow, increase, downward arrow, decrease, N, normal. Acidosis. pH. PCO2. HCO3. 1 acute metabolic. N. 2 compensated metabolic. N. 3 acute respiratory. N. 4 compensated respiratory. N. Alkalosis. pH. PCO2. HCO3. 1 acute metabolic. N. 2 chronic metabolic. 3 acute respiratory. N. 4 compensated respiratory. N. 15.12 Anion gap. Blood plasma contains an equal number of positive ions, cations, and negative ions, anions. The anion gap is a measurement of the difference or gap between the positively charged and negatively charged electrolytes. The major cation is Na+, routinely measured cation, while K+, Ca2+, and Mg2+ are minor cations, unmeasured cations. The major anions are HCO3 and Cl, routinely measured, while minor anions include albumin, Po43, and So42, unmeasured anions. Anion gap can be calculated by following two formulas. First formula, anion gap equals Na plus, HCO3, plus Cl. For example, anion gap equals 140, 24 plus 105, equals 11, normal range equals 10 to 12 mol/L. Second formula, anion gap equals, Na plus K plus, HCO3, plus Cl. For example, anion gap equals, 140 plus 4, 24 plus 105, equals 15, normal range equals 12 to 16 mol/L. The anion gap is either increased or decreased by the presence of unmeasured ions in abnormal amounts. The significance of the anion gap is to determine the cause of metabolic acidosis. A high anion gap value means that blood is more acidic than normal. It is increased in diabetic ketoacidosis, raised to 35 to 40, lactic acidosis, organic aciduria, aminoaciduria, aspirin poisoning and acidosis due to the formation of formic acid or oxalic acid. The anion gap is found normal in metabolic acidosis due to HCO3 loss, diarrhea, chloride retention, intestinal fistula, and renal tubular acidosis type I, 2 and 4. Table 15.10 Serum values of some parameters in various acid-base disorders. Condition: Na+, mol/L, Cl, mol/L, HCO3, mol/L, PCO2, mmHg, pH, normal, 140, 105. 25. 40. 7.40. Metabolic acidosis. 140. 115. 15. 31. 7.30. Chronic respiratory alkalosis. 136. 102. 25. 40. 7.44. Mixed metabolic acidosis and chronic respiratory alkalosis. 136. 108. 14. 24. 7.39. Metabolic alkalosis. 140. 92. 36. 48. 7.49. Chronic respiratory acidosis. 140. 100-102. 28. 50. 7.37. Mixed metabolic alkalosis and chronic respiratory acidosis. 140. 90. 40. 67. 7.40. Summary. Electrolytes are essential to maintain normal biochemical reactions and homeostatic functioning of the body. Sodium, Na+, potassium, K+, and chloride, Cl, are three major electrolytes. Other electrolytes are Ca2+, Mg2+, H+, HCO3, Po43, So42, NH4+, etc. The concentration of electrolytes is generally measured in terms of milliequivalent/L or mol/L. 1 gram mole of a non-diffusible and non-ionizable substance equals to 1 osmol. 1 osmol of a substance is equal to the molecular weight of the substance divided by the number of freely moving particles liberated by that substance in the solution. An osmolarity is the number of osmoles per liter of a solution, while osmolality is the number of osmoles per kilogram of solvent. Under normal circumstances, the total milliequivalent/L of cations must be equal to the total milliequivalent/L of anions in a particular fluid of the body. Sodium is the principal cation in extracellular fluids, as 85 to 90% of all sodium exists here. Sodium deficiency may cause dehydration, acidosis, and tissue atrophy. The main causes of hypernatremia are skin burns, hypotonic diarrhea, nephrogenic diabetes insipidus or due to head injury, and iatrogenic, i.e., intake of high-salt foods. The main features of hyponatremia are hyperkalemia, acidosis, diarrhea, low blood pressure, and decreased heart rate. Potassium is the principal cation of intracellular fluid. Its plasma level is 3.5 to 5.0 mol/L, and 98% of body K+ is found within the cells. ECG changes of hyperkalemia include tall, peaked T waves with a narrow base, shortened QT interval, and ST segment depression. Signs and symptoms of hypokalemia are rapid and irregular pulse along with low blood pressure, lethargy, muscle weakness, anorexia, nausea, and even paralytic ileus. ECG changes in hypokalemia are due to delayed ventricular repolarization as flattened T waves, prominent U waves, increased PR interval, and widening of the QRS complex. The acidity and alkalinity of a solution are measured by the pH scale. pH is the negative logarithm of H+ ion or H3O+, hydronium ion, concentration. The acid-base balance of the ECF is maintained by three mechanisms: chemical buffering systems of blood, ECF, and ICF, 2. Lungs, to control the elimination of CO2, 3. Kidneys, to eliminate H+ and regulate HCO, 3. Acid-base disorders are of four main categories: metabolic acidosis, metabolic alkalosis, respiratory acidosis, and respiratory alkalosis. Metabolic acidosis is the condition characterized by a primary reduction in HCO3 and ECF and blood with a secondary rise in H+ concentration. Metabolic alkalosis is the condition characterized by a primary elevation in HCO3 and ECF and blood with a secondary fall in H+ concentration. Respiratory acidosis is a condition characterized by a primary increase in PCO2 in the blood due to hypoventilation. Respiratory alkalosis is a condition characterized by a primary decrease in PCO2 in the blood due to hyperventilation. The anion gap is a measurement of the difference between the positively charged and negatively charged electrolytes. References. Exercise questions. For MCQ 1 to 5, see Part 1 of this chapter. MCQ 6. A 40-year-old man is brought to ER in an unconscious state. Lab investigations of blood showed Na plus 139 mol/L, K plus 4.4 mol/L, Ca2 plus 7 mg/dl and glucose 192 mg/dl. Which of the following is the most likely diagnosis in this patient? Hypokalemia, hypoglycemia, hypocalcemia, hyponatremia. MCQ 7. Serum electrolyte reports of a patient showed Na plus 132 milliequivalent/L, 135 to 145, K plus 5.9 milliequivalent/L, 3.5 to 5, Cl 94 milliequivalent/L, 96 to 105, HCO3 8 milliequivalent/L, 22 to 26. What is the anion gap in this patient? 35.9, 38, 43.9, 116, 129.9. MCQ 8. Which of the following hormones is most likely deficient in the patient presenting the conditions of hyponatremia and hyperkalemia? Aldosterone, cortisol, epinephrine, glucagon, norepinephrine. MCQ 9. A 68-year-old man admitted to ICU for the management of pyrexia of unknown origin. His ABG report showed pH 7.52, PCO2 30 mmHg and HCO3 25 mol/L. Which of the following acid-base disorders is present in this patient? Partially compensated respiratory alkalosis, uncompensated respiratory alkalosis, partially compensated metabolic acidosis, uncompensated metabolic alkalosis. MCQ 10. A 60-year-old man is admitted in ICU for the treatment of acid-base disorder. Lab results of his arterial blood gases are pH equals 7.20, HCO3 equals 17 mol/L and PCO2 equals 41 mmHg. Which of the following acid-base disorders is present in this patient? Metabolic acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis. End of Part 2 of 2 of Chapter 15. Thank you.